So we'll welcome back Dr. Lori Winter for her afternoon session. And we actually had the title incorrect on the agenda, so you can see the focus of the talk, which I think will be of great interest to everyone in the room.
So good afternoon. I know everyone's CCK is kicking in after lunch. And so you might have that tendency to snooze, but I want to try to keep your attention because I know that a lot of the questions that were generated from this morning hopefully will be answered by this talk, and if not answered by the talk, at least you'll have some new things to think about because of the talk. So really, the title that was in your handout reflects all the evidence over the course of the first 6 months, but I really think that for this audience and because of the discussions of the day, we'll really focus on the delivery hospital and really the physician's role in the Baby Friendly Hospital Initiative. So what can we do? I went through my disclosures. So what I'd like to do is describe how physicians affect system-level changes, that we do have a role, and that, in fact, to become a baby-friendly hospital, while some people don't like me to say this, but in fact, you don't need to have board-certified lactation consultants to be a baby-friendly designated hospital, even though it's not a bad idea to. They might need to change their role job description because they tend to, the lactation consultants that were frontline now tend to take on more managerial and true consultative roles. You do need physicians. So you do need physicians to become designated as a baby-friendly hospital, and you need their input and coordination. And there are a lot of barriers to getting physicians on board, and I'll try to address those as we go through. So again, sort of as unpalatable as this might seem, the truth is that in the United States healthcare system, the way it exists today, physicians, in fact, are the gatekeepers of healthcare. We ultimately are the ones that hold prescriptions and make healthcare decisions and do the billing, and often are in the leadership positions in hospital systems. Now, some hospital systems function with a balance of nursing leadership and administrative leadership, but that's still a balance and coordinated with physicians. So I think that it's important just to recognize the role that physicians play, and engaging physicians in this process can be challenging because they may not have the commitment or attitudes that are shared by all of you. And so if they're not properly educated and brought into the process, best time is at the beginning, but definitely at any point along the journey, they're going to obstruct what you're trying to do. And you will hear just this. I won't do that. Examine babies in the room. There's nothing wrong with giving a supplement. It avoids hyperbilirubinemia or hyperglycemia. And I just won't do that. I'm just not going to do what you're telling me to do. So if you put it as though this is now the new rule, this is what we're doing, you're going to meet up with that resistance, and often it doesn't go well. So it could go better if, in fact, your adversaries can become your best allies. And Ann and I have worked with a number of physicians along the way that have started out by saying, I am Dr. So-and-so, and I am the enemy. Baby Friendly is not working here because of me. And I was asked to speak about it. And initially, those physicians may have a hard time speaking about it. But in fact, the physician that we're thinking about that spoke at this particular conference had a little evolution in attitude between the time we had them speak and the time the conference came around. And, it was really by being invited in and part of the process. That person who was the barrier decided to change the attitude and just be humble enough to say, what do I need to do? What don't I understand here? How can I work with you? And that's really how to push through and use the fact that physicians really do want to make a difference. We wouldn't be doctors if we didn't really want to do well for our patients. It's not the biggest carrot in the world anymore to be a physician, despite work hour restrictions and all the other things. The payoffs aren't there. It's just not the same era. Our student dean at the medical school reminds me almost daily, don't be so harsh. You don't understand what these students are going through. You don't get it. They're not in the same framework that you were in. Their debt, is sometimes 2 to 3 times the amount of debt that you had. So why are they doing it? If all they want to do is obstruct good care. So that's not the case. Physicians don't want to obstruct good care. I can tell you from a number of different things that the government has put in place in the ways of carrots and sticks, and now there are many carrots and sticks to do the right thing in healthcare, whether it's pay for performance as a carrot, in a way that's a stick, or HCAHPS score, which could be a stick if you don't exceed that 50th percentile based on patient satisfaction, if you don't put in place and abide by meaningful use, if you don't have an electronic health record in your outpatient office. I mean, it's almost overwhelming enough that you think, why did I ever decide to do this as a career? Because there's so many things that have been thrown at physicians in the last 5 to 10 years as carrots and sticks to just be able to practice medicine. And that's the health system, let alone what we have to do individually now to maintain our board certification. It used to be it used to be people were grandfathered. You were board certified and that was it. Good for life. And then recertification came on board and that was taking a test. We're good at taking tests, so that wasn't so offensive. And then it was like this 5-part process that cost, an extraordinary amount of money and required maintenance and certification and taking on a QI project. We weren't even trained in quality improvement. How would we do QI? And so that's what's happening right now. And I can tell you there's a lot of battles between the different physician organizations about whether or not, that should even be the way to go to maintain board certification. The internal medicine group and cardiology group, is screaming very loudly against doing this. The AAP, which an ABP, the American Board of Pediatrics, was one of the trailblazers, almost embarrassed to say, in introducing the mandate to have this maintenance of certification. So it's just a lot. So you have to kind of understand that culture, that there's a lot of carrots and sticks. And I would say that for Baby Friendly, we talked about carrots and sticks early on, about getting education, what could be the carrot, what should be the stick of not getting your education, not passing the test, not doing what you need to do. And after a while, through the Best Fed project, occurred to me, oh my gosh, we're only one more thing that's producing carrots and sticks, and we can't do that. We really have to bring physicians in really for the greater good, and so that they realize that making the changes that are going to facilitate this kind of care, that are going to facilitate designation, at the end of the day, they're going to be able to say, I was a part of that. I was a part of that. And look what great things happen. Look at our breastfeeding rates. Look at how well that mother and baby bond and take care of each other, and how the mother appreciates the care that everybody connected with the health system provided for her and her family, and how grateful they are. And so I think that that's really the way to go, to convince physicians to be a part of it and change. So it's also important to know how we got to where we got to in terms of our knowledge deficit. So back in the mid-'70s, when breastfeeding was at an all-time low in the United States, Holland did this study just surveying pediatricians to ask, so how often do you recommend breastfeeding? Answer, 30% of the time. If a mother says she wants to breastfeed, how often do you recommend breastfeeding? 50% of the time. So even when mothers wanted to breastfeed, the pediatricians of that time, because breastfeeding rates were so low, weren't even recommending breastfeeding for most mothers. With public health efforts, breastfeeding went on the rise. Guess what happened then? Any guesses? Right, marketing, direct-to-consumer marketing. So this is when direct-to-consumer marketing happened. We hit a plateau. And then Gary Freed, in 1995, did his landmark series of articles describing studies asking physicians and practicing physicians and residents and medical students about what they thought of, what their attitudes were about supporting breastfeeding, but then also what their confidence level was. And while 90% wanted to support breastfeeding, less than 50% felt confident in their ability to support breastfeeding. And that was at every level of training, every discipline. So that was problematic. And we continue to see this widening gap, interesting, right? This widening gap between overall breastfeeding, meaning women were initiating breastfeeding, yet exclusive breastfeeding was really stagnating for a long time. So more and more, so really what we were seeing was an increased number of women in the United States giving both. And we went back here with the periodic survey that's conducted by the American Academy of Pediatrics. Chandler was first author on that paper and discovered that a little better than 30% of pediatricians selected the correct response for what should be the proper duration for exclusive breastfeeding. So this is the first time we started surveying doctors about what they thought about exclusive breastfeeding. We didn't know. And then in follow-up to that, 10 years later, we did a little better in adhering to the recommendations, but more times than not, we thought that mothers shouldn't persist if they encounter difficulties, and breastfeeding's too difficult. If mothers are encountering difficulties, don't outweigh the discomforts and costs and other barriers that come up. So still major attitude issues. Even in our most recent study, we actually just got our 10-year data back, and we'll be analyzing that to see sort of the state of the state in the pediatrician's mind about breastfeeding among U.S. pediatricians with that periodic survey. So more to that story. So what does the top of this graph then tell us? Well, it's these guys here that weren't recommending breastfeeding who taught these guys, and it was mostly guys, even though I was among them, we were the minority back then, they just didn't know anything to teach us. They didn't talk. There was mainly, the tie line, well, let's learn about formula, and the way we learned about infant nutrition was actually in a conference room with all the industries that came in with their samples of product around a table, and at the end, oh, by the way, and breastfeeding's best. That was all we really learned. So that's who trained us. So we didn't learn a whole lot. So we didn't feel confident if mothers even were breastfeeding on how to help them. Some of us never even got any months of rotation on Well Baby. So we didn't even know how to take care of a Well Baby. I had 7 months of NICU, and I had no months of Well Baby. I knew how to take care of really sick babies, and I knew exactly what Well Babies didn't have, but I didn't exactly know how to advise Well Babies on how to manage them. And so then we are teaching the new generation of guys and gals, and more gals than guys, according to the recent statistics, and I think that plays in. I'm going to show you why in a little bit. And so we're still not ready. We're not ready for prime time. Like, our faculty really doesn't have the knowledge and skills and competence to be able to teach the next generation about breastfeeding. We have not done a good job with faculty development. We try locally. I've mentored a young faculty OB doc to be able to give the lecture to the second-year students in their women's health block about breastfeeding. And she was like, oh, my God, I just learned so much about physiology that I never knew, And she's a young female OBGYN doc who has 3 children who she breastfed, but still never really learned the basic sort of medicine take on how to teach this topic. So it's quite frustrating. This is just more evidence to show that the number of hours that residents receive is really low throughout their entire residency period. And this is just an illustration of the study I alluded to earlier, where we compared the 95 data to the 2004 data, basically that our attitudes got worse, that we don't think that mothers can be successful, even if she keeps trying, and that the benefits really don't outweigh all those barriers and problems and inconveniences that moms bump up against. What we also found in the study is that personal experience really matters in a good way, in that those who had personal experience were much more confident in their ability to help breastfeeding. But that's kind of annoying that you have to have personal experience to be able to help mothers. I mean, it really should not be dependent on personal experience, right? We don't demand that of any other disease or health issue that we take care of. But really everything related to attitudes and practice patterns, how often the pediatrician helped somebody with a breastfeeding issue is definitely related to whether they had experience. So we embarked on this residency curriculum project, and we knew that the traditional curriculum models start with what we think should be in a curriculum, and then we set the objectives, and then we assess our subjects. But really, newer thoughts of how curriculum should be developed really emanates all from the health needs of the system. And so when we think about breastfeeding, what are the health needs? So if you made a list of what you thought your doctors need to know and are having issues with in terms of being able to support breastfeeding and the Baby Friendly Hospital Initiative, that's where you start when you write a curriculum, right? We started with the core competencies when we wrote the residency curriculum and developed a curriculum that was based on the ACGME core competencies, and lo and behold, in our study looking at the programs where we piloted the residency curriculum versus those that we didn't, we found that the residents that were exposed, and these were pediatric, OB, and family medicine residents, were 2 to 3 times more likely to have better knowledge, better confidence, and improved practice patterns related to their residency experience. And what was really cool is that we discovered that residents matter. So despite how badly educated the faculty is, if we can do something, if someone can be educated in the faculty in order to roll out the residency curriculum, and that's an if, then by educating those residents, you actually end up seeing more mothers exclusively breastfeeding for a longer period of time. So more mothers in the continuity clinics continue to exclusively breastfeed for the first 6 months, and that was really nice. So how do we think that works? Well, we think probably through this health systems theory of diffusion of innovation, that we have these few trainers that develop a curriculum, faculty development, missing link. But we have these residents then that became the innovators, and these innovators started to impact practices. They had the frontline interaction with the nursing staff, and they said to us, those that were in the pilot study said, if we were a baby-friendly hospital, it would be a whole lot easier to roll out this residency curriculum. And sure enough, some of them went along that pathway. Because of that, it was really synergistic. Those that were implementing the residency curriculum actually were better at going through the baby-friendly pathway, and vice versa. Going through the baby-friendly pathway makes it a whole lot easier to implement a curriculum, because now you have breastfeeding mothers as opposed to not having breastfeeding mothers, and there's more opportunity to practice and learn. But I think that this slide actually tells it all. So as much as our residents are our innovators these days, because our residents are, for the majority, are female. And I think, and this is hypothetical, although there's probably some evidence to support it, because of work hour restrictions during residency, not that that's a bad thing, we are seeing more and more residents childbearing throughout residency. So this is a no-brainer, I think, for anybody that's working in a hospital with an academic medical center with residents. We're seeing lots more babies being born during residency. And so using the same type of tool that we used for the periodic survey that was developed by the AAP, we have a SOMFRIFT, which is just an acronym that is the section on medical students, residents, and fellows from the AAP, and we surveyed that group with a similar tool, but we asked some open-ended, more qualitative questions in that tool about what their experience was like having children and then wanting to come back and breastfeed, and were they supported. And actually, the title of the article says it all, right? Which is devastated, disappointed, frustrated. You know, these were the words. This is what's called like a word chart that makes the word that's mentioned most often the biggest. So all these big words are the things that got mentioned most often by our young women residents who were trying to come back to work and continue to breastfeed or pump, about the experiences that they had. So we as a health system are not doing very well in supporting the next generation of physicians to then be able to support whatever endeavors we have around baby-friendly or breastfeeding. So I think it's really all connected, and I think that we just have to think more strategically about how to walk the talk. You know, if we're going to support mothers that come to our institution to breastfeed, how can we then support our employees, the people that work in the hospital, and certainly the physicians in training to do this. So this is a slide that was authored by a friend of mine who worked on the leadership track of the Best Fed Project, Steve Blattner, about how you get physician buy-in. And I think that this really summarizes everything I've been saying up to now. Really treat the physician like you would treat a patient. You know, listen and empathize and build trust. Now, you know, there's other approaches. You can batter and assault and humiliate. And maybe there's room for some of that. But really, this is about building a relationship that's going to be long-standing. And so respect is important, and most importantly, respect physicians' time. We're under the gun. We have to see, you know, sometimes as many as 8 to 10 patients in an hour, which is crazy. And so we don't have time. So, you know, running everywhere, and so be respectful of their time. Make this initiative be quantitative for them. So physicians like numbers. We tend to be pretty good at math. So if you can show a lot of charts and numbers, that will definitely help. Communicate, link the work to performance and quality. So, you know, show that if a physician did an exam in the room, how that relates to quality and how the families actually perceive that care as better. Communicate that then back to the physician. You know, giving good positive feedback is never harmful, so that's a good thing. And addressing that skepticism head on, knowing what the problems are going to be, such as exams in the room, bad lighting, et cetera. And there's some other, you know, solutions that I can mention about how to do that. And then definitely reward, not provide that carrot, but just recognize efforts and recognize when people are going along and doing something different when the change is actually happening. I'm turning